In this unit, we are going to talk about speech and language disorders in adults that are associated with neurological impairment. Neurological impairment, of course, means impairment to the brain or associated with the brain. So we know that specific areas of the brain are associated with specific functions. For example, handedness. If you're right-handed, that means you're left brain dominant. If you're left-handed, that means you're right brain dominant. As you remember from the anatomy and physiology section, there are two main areas of the brain, Broca's area and Wernicke's area, that affect language or speech and language. Wernicke's area is located in the temporal lobe, and Broca's area is found within the frontal lobe. Wernicke's area is primarily responsible for comprehension of speech and language and the formulation of language concepts, and Broca's area is related to that programming or motor speech programming and production of expressive speech and language. There are strong connections between Wernicke's area and Broca's area. Information must be transmitted from Wernicke's area to Broca's area. That connection, or the place that communicates that information between Wernicke's and Broca's, is called the arcuate fasciculus. It's important to note that every individual is different, so the way this communication takes place or how much information is in one area versus another area can vary across individuals. So let's talk about language disorders associated with neurological impairment. Aphasia is the loss of language or the loss of the ability to comprehend or express because of neurological damage. Aphasia can be caused by a number of neurological conditions, but the most common is stroke, or CVA, cerebral vascular accident. When a CVA occurs, there's blockage in a blood vessel that's providing blood to the brain. So there can be bleeding in or around the brain or blockage, and the brain is deprived of oxygen and nutrients, so this causes brain cells to die, which is going to in turn impact language or other abilities because certain brain function is no longer working. Strokes are said to be the leading cause of serious long-term disability in the U.S., and over 80,000 people become aphasic each year. We can classify language deficits associated with aphasia according to anatomical perspective or according to the communicative perspective. We can look at patients' strengths and weaknesses according to their language functioning. So a lot of times we will look at these aphasias as fluent or non-fluent. And fluent has normal rate and rhythm of speech, but no meaningful content. And non-fluent is characterized by difficulty initiating speech or choppy, short utterances. And sometimes there's some articulation deficits. So some other expressive language problems associated with aphasia is something called anomia. So that's like that ability to think of a certain word. So if you're sometimes if you're talking to someone and you might can't think of that, you know, that thing that you use to stir with. So you know. So it's the difficulty with retrieving and producing words. There's also something called a paraphasia that can be an expressive language problem, and these are sound word substitutions that can be found in the speech of aphasic patients. So for example, instead of a ring, I might call it a bracelet or a necklace, or it can be associated with that word. Or I might say, instead of a pen, I might say a hen or a tin. It can have some sound differences. Or instead of a television, I might say a computer or something else with a screen. So it might have something associated with it, but or instead of a book, a magazine. So those are paraphasias. Also, a neologism is something that an aphasic patient might use. These are made up words. So, for example, some might say, "Can you go to the bogobo?" And they really are meaning go to the bathroom or go to the kitchen, or so they might just use a made up word. Agrammatism is a deficit exhibited where patients leave out articles or conjunctions. And even morphemes, certain morphemes might be left out. So, for example, the patient might say, "I go school." "Want pickle" without "I want," or pickles if it's more than one. They might leave off that S. Also, they might use jargon, which you should remember what jargon is from our section on normal development. So jargon can be used with English words and the made up word. So you might say something like, "I am gushy, want, and some she always." If you're not listening very closely, the rate and intonation can sound normal and like normal language, but there's made up words in there or there's some jargon in there. So it can be a combination of some true words, but then it may not make very much sense if these other substitutions are included. So when we're looking at comprehension, auditory comprehension requires a person to understand the meaning of the word spoken and the grammar associated with the utterances. Just like expressive language deficits, auditory comprehension or language comprehension problems vary from individual to individual. And it could be difficulty understanding the vocabulary. It could be an inability to understand multiple words at a time, so depending on the number of words that are spoken. So the speech-language pathologist has to know, but from the family, if the comprehension is improving, because what did they do before? So they have to know, did they usually use more words when they answered a question, or did they use less words, or did they make more sense when they answered questions before, or when they made statements before? So you kind of have to compare it to what the family knows about the patient. So the family, also you have to look at what's realistic for the family. So the family may want their family member to use really long utterances and say more words like they used to, where they're only answering in 1 and 2 word utterances, but the speech language pathologist may have to work with them to help them understand that at least they're communicating, or they're following directions, or they're making some progress by at least maybe even writing something down, or answering simple questions, or following simple commands. So it's important for the SLP to keep track of the initial problems and then how much progress they're making over time. Something else that might be a problem in comprehension is agnosia. Agnosia is difficulty identifying sensory information. So this is the patient's ability to perceive sensory information such as hearing or visual information. So they may experience word deafness or verbal agnosia. So when they're reading something, it may look completely different than what it really is. So an example of visual agnosia may be difficult for someone to recognize a face. A face may look different than it looked before the stroke. So agnosias have the potential to really impact a patient and the patient's family if they don't recognize you, or they can't read or write or speak because of these, because of their hearing agnosias or their visual agnosias. So you can see that those could really impact quality of life. Some other deficits in reading and writing might include agraphia, which is the inability to write. Grapheme is the written symbol of a letter. So agraphia is the inability to do that. Problems associated with reading are called alexia. So you're probably familiar with the term dyslexia, or developmental dyslexia, and it describes a child's reading difficulties. But a patient with alexia had normal reading at one time, and now, because they've had the stroke or neurological damage, they have mild or severe reading problems. So know the difference between dyslexia and alexia. So in its most extreme form, alexia could be classified as visual agnosia or word blindness. Let's now look at the different types of aphasia. Broca's aphasia is the first aphasia we'll look at, and Broca's aphasia is characterized by non-fluent speech and language. A patient with this type of aphasia can produce sentences, but they usually contain nouns, verbs, and an adjective, and their conversational comprehension appears to be intact, but when more complex comprehension is required, the patient has difficulty comprehending the syntactical relationship. So, for example, if someone was asked a question, do dogs bark? The patient could say yes, because that's pretty simple. They could say that. However, if they were given a statement like, the Ole Miss Rebels are going to play the Memphis Tigers this weekend, the patient might have trouble answering a question like, who's playing? So patients with the Broca's aphasia have problems with confrontational naming. So, because that requires the patient to produce the name of an object in a fast manner. So they have difficulty with oral reading and sometimes reading comprehension. And they also, it depends on the lesion of the brain or where the damage is. Broca's aphasia is considered to be a disorder of expressive language or expressive output. Wernicke's aphasia is where there are lesions on the upper portion of the temporal lobe, which is Wernicke's area, and this is viewed as a fluent aphasia. And the patient here exhibits difficulty with comprehension. So someone might say, a family member might tell you as a speech-language pathologist that the patient's trying to tell us something, but they don't really understand what they're trying to say. So the patient with Wernicke's aphasia will use paraphasias, neologisms, jargon, so they might not be fully understood when they're trying to communicate. So patients have significant comprehension problems to the point that they don't understand spoken language. And they may have difficulty with reading. So they have trouble with both comprehension and expressive output. Global aphasia is more severe than Wernicke's aphasia. It affects almost all language areas. So a person with global aphasia usually has non-functional language skills in both the receptive and expressive areas. So expressively, the patient might just produce stereotypical expressions like hello or I'm fine in response to a question. And then they also use jargon to produce meaningless utterances, such as da da ba ga ga, blah ga blah ga. They may perseverate, where they repeat the same thing over and over again. Anomic aphasia has to do with word finding. So the patient with anomic aphasia often exhibits normal to mild. So how do we evaluate? So once the patient has been evaluated, the different treatment options are then looked at. So treatment is usually just focused on one main goal, and that's to help the patient with this neurological impairment to return to a level of functional communication. They want to be able to communicate with their family. They not be back to where they originally were, but can they rehabilitate to a place where they can just functionally request or get their needs known. So functionality is always going to be related to each individual's daily living situation. So what is the environment that they're living in? Who is in their life? What are they needing to communicate on a daily basis? Family involvement is a strong factor. So are there different people that are going to be helping and practicing communicating with them? Or are they living alone? Can they continue to live alone? Do they need to move in to a nursing home or some assisted living facility? Is there someone that can live with them if not already? The results of the evaluation serve as the foundation for treatment planning. So you come up with a treatment plan based on your evaluation. So the SLP is looking at the patient's strengths and their weaknesses. So what can they already do and how can you build upon those strengths? And then what can they not do? And then how can you help them be better at those functions? So basically you're helping the brain reorganize. So if someone has difficulty naming objects, for example, the SLP might design a language activity that helps the client name certain objects that they use on a daily basis, such as utensils or certain foods or things in the bathroom or things around the house that they use. So the SLP will encourage them to fill in the blank. We cut with a blank. We eat with a blank. The SLP is working to stimulate these language abilities. If it's someone who is younger and has had a stroke and they had a job, they were working, then you may be trying to rehabilitate to get them back in the workplace for functional communication at work. You might be working on goals that are related to their work environment. They may not can return at the ability, the level that they were before, but can they return at some level? Can they use some functional communication skills? So you might be working on answering questions or even composing emails or writing out sentences. Family members must always be a part of treatment. So they have to always be educated about what's going on. They also can provide you with critical information about what they're doing at home and who is in their life and where they're having communication breakdown, where they're having trouble. You might determine that a person with who has had a stroke may need a support group or some other people that have had strokes where they can all communicate together and help each other. There might be something online that they can be a part of. There might be other professionals who could participate in the group, OTs or PTs, or Maybe there's just other people, psychologists or behavior therapists, who might want to participate or help. When you're in treatment with someone who's had a stroke, you may have to use certain compensatory strategies or cues to help them remember what they're trying to talk about. For example, visual cues. So I had a patient who will start talking about someone, but they won't reference who they're talking about. So we don't know if he's talking about his wife, his sister, his mother, his friend, and he'll just start talking about this person. So we have to teach him to say, my sister-in-law, Jamie, or my mother-in-law, Betty. We have to always tell him to reference, and we do this by using visual cues. So we might write on the board or write on a piece of paper some words every time for him to start of who, and then every time he has to say my brother or my friend, or so that he starts to reference those, because he always forgets to tell who he's talking about. So he'll leave out certain context cues. He leaves out really important information that we need to know so we can understand what he's talking about. So up to this point, we've mainly focused on brain damage that would occur with the left hemisphere, which is where language is primarily developed. But let's talk about what happens when the right hemisphere is damaged, or what's called right hemisphere brain damage. RHD is what it's sometimes called. So this can affect language and non-language related problems. Usually many deficits that are associated with RHD can be cognitive communication problems. So we know that these problems did not exist prior to the stroke or the head injury. So for example, maintaining attention or problem solving, reasoning, organizing, the ability to monitor their own speech, the inability to appropriately respond during conversation with multiple people, not being able to read his listeners. So there are three main areas that seem to be a problem when you're dealing with RHD: communication, attention, and attention and perception go together, and cognition. So someone with a right hemisphere damage might have difficulty with idioms or humor, making inferences. If someone said it's raining cats and dogs, or I don't rock the boat, they may not understand what that really means. Are cats and dogs really falling from the sky? Is there a boat somewhere? I mean, they don't really understand what's going on, where they used to understand that. Or someone might tell a joke and they don't get it, or they're taking it literally. They take fewer conversational turns. They don't really always get sarcasm. They may not be able to focus. Their attention is could be affected. There's some left neglect. So if it's right damage, that's going to affect the left side. So there might be left visual neglect. There might be hearing and taste and touch on the left side is not working, or the hand and leg, that might be all weakness on that side. Sometimes with that left neglect, if someone is reading something, they may not see anything on the left side They see everything on the right, so they're leaving out critical information when they're reading a sign or reading a book even. So cognition is also affected. So what is cognition? That's their ability to reason, problem solve, put things in order. So it's difficult to for them to kind of plan that executive functioning. So they have organizational problems. A lot of times if there's right brain damage too, there might be some emotional difficulties where the person might have outbursts where they never had outbursts before. They might cry eat more easily. So another injury to the brain that can affect language is traumatic brain injury. This is an acquired injury to the brain because of a head injury. So that could be because of a gunshot, war injury. Professional football players or even college football players can have TBIs. Motor accidents, any kind of trauma to the head. I knew someone that was hit in the head with a baseball. Concussions can be a mild TBI. TBIs can cause death. They can cause severe disabilities, and then they can cause mild disabilities too. It is believed that 1.6 million to 3.8 million sports-related TBIs occur every year. So that is a lot of injuries. There's some research right now being done, even at Ole Miss, on concussions and the long-term effect of concussions, getting more than one concussion over time. They're trying to measure that and look at that. And there's a device they can put in football helmets and kind of determine the impact. And they're trying to measure, how are concussions affecting football players over a long period of time. Are these helmets providing adequate protection? Some symptoms that follow a TBI might be fatigue, headache, sleep problems, memory problems, also emotional issues, memory and attention problems. It is common for these people to have other language deficits. They can have aphasia associated with TBI. I actually recommend that you read on page 155 and 156. There are examples of some brain injuries. Some patients receiving services, how it affects the family, might be very helpful for you to understand what's happening in these patients' lives. I think they're pretty good examples. So individuals with TBI are going to need help probably from an OT, PT, speech language pathologist, maybe a psychologist, just like people with stroke. So let's talk about another disorder. This disorder is dementia. You probably have heard of dementia. You might have heard of a chronic disorder called Alzheimer's disease, which is a form of dementia. So what dementia means is really memory. It can be short-term or long-term memory loss. Alzheimer's or Pick's disease, which Pick's disease is actually the shrinking of the brain, of the frontal and temporal lobes. So that really affects memory. Multiple strokes can cause dementia, other brain disorders, even TBI can cause dementia. Diabetes can cause dementia. So usually it has to do with memory. If a person has a sudden onset of problems, that's going to usually be associated with a stroke or brain injury. But if it's over time, that's going to probably be dementia. So it's usually a gradual onset. So we've been talking about language disorders associated with neurological impairments. So let's now talk about motor speech disorders. One common motor speech disorder is what's known as dysarthria, and that's resulting in paralysis or weakness. There's several different kinds of dysarthria. There's spastic dysarthria that results in slurred speech or a slower rate of speech. You also can have trouble with the vocal quality. There's ataxic dysarthria, which has to do with the cerebellum. And cerebellum contributes to the person's ability to coordinate their muscles. So kind of, we've talked about before, the cerebellum kind of, it's coordination. So if there's a deficit there, it might tend to cause someone to sound like they're drunk, or their motor skills may appear like they're drunk. So you can remember a taxi. I need a taxi, so it's ataxic. I need a taxi because I'm drunk, so I have ataxic dysarthria because it's affecting my cerebellum, and when I'm drunk it affects my cerebellum, so that's a way to remember that. The patient may exhibit a slow, slurred rate of speech.
Chorea.
Chorea is a disease or disorder of excessive movement. One major disease is called Huntington's chorea. So Huntington's chorea or chorea is when the body has frequent, irregular, rapid movements of the speech muscles, limbs, or the whole body. Hyperkinetic dysarthria is a speech disorder that is associated with chorea. And then so where it's rapid movements is hyperkinetic, but hypokinetic would mean there's more rigidity or stiffness to the muscles. So hyper means excessive and hypo means less. Parkinson's disease results in muscle rigidity, stiffness, and an inability to move quickly. So, Michael J. Fox, for example, has been diagnosed with Parkinson's disease. And so that's that hypokinetic or rigidity, stiffness of the muscles. Sometimes they have a hoarse vocal quality. They may even have tremor in their voice. And then there's something called mixed dysarthria. And you may see mixed dysarthria in the disease like ALS. And so ALS is Lou Gehrig's disease. And the ice water challenge that was going on last year that was so popular, that was to raise money for ALS. So someone who has ALS or Lou Gehrig's disease is the other name. Lou Gehrig was a famous baseball player who died from that disease, so it was named after him. But patients often exhibit characteristics of both the flaccid and spastic dysarthria. So they may have the slower movements and be stiff, or they may have some of the rapid, faster movements. They can have kind of a combination of both. The disease attacks the body. It's a vicious, vicious disease. And I had a real good friend that that had ALS, and she died from it, and it was just really, really a very hard, mean disease. So Stephen Hawking has ALS and unable to verbally communicate. And he had that AAC device has kind of become famous, his synthetic speech. Another disorder, motor disorder of speech, is apraxia of speech. And this is a motor planning disorder, so it's the inability to be able to produce learned speech movements. And there's childhood apraxia of speech, which we've talked about, but this is apraxia of speech that affects mainly adults, or is acquired apraxia of speech. So speech may be slow, or there might be distortions of sounds. It's a speech sound disorder, so there's this motor planning or programming of where to get the articulators, where they need to go to say what they need to say. So words and sentences may be difficult. Initiating speech may be difficult sometimes. And it can be inconsistent. So for one second, they may have trouble saying a certain word, and then a few minutes later, they can say that word fine. So the errors can be very inconsistent. So speech pathologists treat speech motor disorders. There's a variety of ways. The goal is for them, again, to have functional communication. So they may help them have some compensatory strategies in saying some certain words, or they may give them more opportunities to repeat words, so have more practice of certain speech movements. They don't have any muscular weakness, so there's nothing to strengthen here. There's the muscles are all fine. It's the planning part of the muscles, so where they need to go and how they need to get there. Sometimes a patient might need an augmentative or alternative communication system. They may need to use a device, such as Stephen Hawking did. So as you can see, language and speech disorders associated with neurological impairment